Thank you very much, Shira and Jörn, and thank you, everyone. Very kind. So I'm going to be talking about models of care, and this has really been a theme throughout this meeting. So I realized today that it was kind of strange to have a talk just called models of care when that's really what we're talking about when we're talking about in innovations, and as we heard this morning in the patient roundtable, innovations that mean something for the patient, which is really rejigging and rethinking the models of care. And we put, that Jörn and I, as we worked on the program, the idea of policy and public health endpoints. So we're all familiar with our clinical endpoints from trials, relief of symptoms, survival, quality of life. I'm going to try and think a little bit about what some of those endpoints would be in terms of models of care, and the discussion this morning really will help us in our discussion think through what that means also from the patient perspective, because it's not just about the treatments and care we can provide to patients and those who aren't even our patients yet, but who are in risk groups. But it's about how the care system is really working for them. These are my disclosures. So the main objectives of this talk will be to look at the impact of NAFLD and NASH and these new innovative models of care. I'll talk a little bit about what's being done globally, because as Shira mentioned, I'm vice chair of the EASL International Liver Foundation, and the foundation has really been the arm of EASL working globally with partners to address, as Donna mentioned this morning, the public health aspects, to try and take on that mantra that, liver health is public health. And I would say also, being in the Barcelona Institute for Global Health, that it's also really global health. What still needs to be done, just some reflections to get us going, but I think that will be something we capture in the various roundtables the rest of the day, how we can advance against this often and very silent but serious condition. So why should we be concerned about NAFLD as a public health issue? Well, if you don't know the answer to that question at this point, you haven't been listening really at all. That's what I would say to my students. You've all failed. So I think we all know, and we heard from Zobair the latest numbers, the latest estimates. We know the challenges with those estimates, but really 1 in 5, and earlier in the 2016 study he led, it was 1 in 4 adults and 1 in every 8 children is thought to have non-alcoholic fatty liver disease. We know it's making a significant impact. It needs to be more studied, but the health, but also the economic, and importantly, the social implications. And I'll come back to that towards the end when I talk about stigma and the approach the EASL Lancet Liver Commission took to that. It's a complex challenge, and so are the models of care we need to address this. It requires us to work across disciplines and sectors to find solutions, and that's why we've been so delighted to see so many different disciplines represented at this meeting, but also to hear from some of the hepatologists that they really haven't had that engagement really ever with general practitioners, and they have with endocrinologists, but not so much time, often just listening to their talks, not being able to have the conversations we're having. And we know that in spite of a few small successes in general, NAFLD-NASH has received little to no attention from policymakers, from leading decision makers, and even from our own public health community. I can't tell you how many times, I'll go to a public health meeting, and now hepatitis C is making it onto the agenda a little bit, B a little bit in the context of vaccine preventable infections, but fatty liver disease is not, and not ever mentioned at all. So that's something we need to change. And speaking of change, how is the liver landscape changing? Well, we also heard from Dr. Younossi that the deaths and DALYs attributable to cirrhosis increased, as did the proportion of all global deaths to cirrhosis, and liver cancer is now the second leading cause of years of life lost among all cancers globally. NASH is a leading cause of progression to cirrhosis and HCC, and an increasingly common indication for liver transplantation. With the expansion of prevention, and in particular treatment measures for viral hepatitis, we're seeing NASH overtaking viral hepatitis in the near future as the attributable cause for cirrhosis and liver cancer. So it's interesting that one of the reasons we're getting more attention on NAFLD and NASH, and children are very welcome, is the success we're having in in HCV, as we're seeing fewer HCV cases progress to cirrhosis, to HCC, we're starting to pay more attention to NASH. And on a societal level, NAFLD is already resulting in substantial and anticipated healthcare and economic losses and reduced health-related quality of life, and I'll come back to that. But that's why we need the public health responses that reflect this reality and are so sorely lacking. Juanma, or Dr. Pericas, in the back of the room, and his group led a study recently reviewing the social determinants of health for fatty liver disease distribution and outcomes. And what they found was that low socioeconomic status is associated with NAFLD, with NASH, and with liver cancer. And Shira, you alluded to this yesterday, that people in food insecure households have a higher risk of NAFLD because they don't eat as healthy a diet as those who can afford to. So I think it's important for us to always remember the populations we're working with, and that many of them are disadvantaged in many ways and not able to follow the lifestyle modifications that are really the only course of treatment we have, at least that are specifically targeting NAFLD and NASH. In 2020, the EASL International Liver Foundation set out to understand what policies are in place across the then, all EU countries, I would say, including the UK. And what we found, as you see on the right, was that no countries were reported to have any NAFLD or NASH strategies, and no countries were found to be well prepared to address NAFLD NASH. So as we expanded this around the world to 102 countries, data mining, reporting back the data, we used the data to develop a policy index by coding it into 6 domains: policy, guidelines, civil awareness, epidemiology, detection, and management. We categorized the domains by high, medium, or low level based on a predefined criteria, and then we conducted an MCA, a multiple correspondence analysis, that showed us that no country, according to this data, was found to be well prepared to address NAFLD. In fact, close to a third of the countries around the world received an overall score of 0. So as a researcher, I would always say the results can assist countries in identifying priority actions to improve their NAFLD preparedness. In the case of the countries scoring 0, that's really everything. But for countries that scored higher in the 30s and 40s, they did well in some domains and poorly in most domains. So it can start to guide that response. We can also use this index to track progress over time, global progress and national progress. So if we're going to be talking about endpoints and policy endpoints, where do we want to end? Well, first we need to define the policies we want to have in place. So we started to do that for this index, but I wanted to give you this example from hepatitis C, where the Lancet Commission a couple of years ago identified what policies do we need to have in place in order to best be able to eliminate hepatitis C. So looking at the high burden countries across the x-axis, you can see the policies we need in place. On the y-axis, you see the countries divided by region. And if you go down to the second to last line, like Spain, you'll see that Spain has most of the policies in place. It's also a country that's ranked second in terms of eliminating hepatitis C across the country. If you go through the Middle East, you'll see many countries reporting white, that they don't have policies in place for those particular issues, and then in pink, countries that are working on it. You can also go through the columns and see that some policies, well, there's very few countries that have those policies at all. So you can look at this by country, you can look at it by particular policy. And you might look at estimated economic burden and see that only Egypt has been able to do that. Egypt, we know, is one of the countries that was most affected by hepatitis C. Turns out they had the highest prevalence. They felt it would be affecting the economy of the country. They carried out that study, and now they've launched the largest hepatitis C elimination program in the world, at least in terms of numbers treated, with over 1 million people treated. So I think really all of these policies can be useful. When I presented this to hepatitis C patients, they said, yes, we have those policies in place, but they need to be implemented or better implemented. So one endpoint is having the policy, another endpoint is actually implementing it. What does this mean in terms of strategies and policies for addressing NAFLD? The first question would be, Does your country have a NAFLD, a NASH strategy? And Donna, before you jump up, we know that thanks to GLI, the US is the only country to really have that strategy in place. So this is what happens with research, right? It's always a couple years behind the reality, but all of the other 101 countries didn't have that. And you might say, well, that's okay if you don't have a specific strategy or action for one particular condition. But then you think, well, what are the related conditions? Obesity, we've been hearing about cardiovascular disease, liver disease, and more generally, diabetes. Well, surely the countries that have action plans or strategies in those countries would at least mention liver disease in passing, if not actually have an entire section dedicated to fatty liver disease. In fact, if you look there, under liver disease, under diabetes, 0 out of 95%, out of 95 strategies and actions in different countries. And Ken might correct me, but as the data changes, but in the few other strategies of related conditions, of comorbid conditions, when liver is mentioned, it's usually as a part of the word deliver, to deliver on diabetes care, to deliver on addressing obesity, and not mentioning liver care itself or fatty liver disease at all. So again, then for us, the endpoint in policy will really be to first get those mentions in the other strategies and then actually develop them so there's something meaningful, since we're never going to really be able to address fatty liver disease on our own, speaking from the liver community. And we have here the evidence that it's not being well addressed in the strategies of action plans that are existing in countries. That doesn't mean individual clinicians aren't addressing it, but we're lacking the policies and strategies that we need to be in place. So NAFLD care requires these multidisciplinary approaches. And there's also a dearth of guidance on how to develop these kinds of multidisciplinary models of care. We reviewed the literature, found 7 published examples, one from Manolis, who spoke yesterday and isn't able to join us today. We asked questions about what services are provided, where are they provided, who's offering them, how are they coordinated and integrated within health systems. Again, there's probably more models of care that are fit for purpose. You need to publish and share those examples, because when we reviewed the literature, when we looked at recent conference abstracts, we weren't finding them. So we put them together into this expert recommendation to synthesize the findings and come up with 8 recommendations that should be relevant to policymakers and practitioners, so we can get models of care that are multidisciplinary and provide the best practices for patients with NAFLD. This is what they look like. So this is, again, these could be endpoints for models of care. In terms of the what, it's about having guidance on screening and testing with non-invasive tests, establishing patient-centered pathways tailored to the disease stage. We heard yesterday, or also this morning from Jose, that it's not just about addressing NAFLD when you're there with an with a F3, when you've been diagnosed with F3. It's about reaching people earlier in the course of the disease. Outlining actions to prevent disease progression, developing guidance on treatment strategies related to each disease stage. And the where, well, articulate the roles of and interactions between primary, secondary, and tertiary care. Establish where co-location of services for the treatments of NAFLD and common comorbidities is feasible. When we talk about integrated care, there's co-location, there's also just having effective referral systems. It's not necessarily about putting everything in one place, because we know that that can always be challenging. How? Well, establishing systems for coordinating and integrating care across the healthcare system, and the WHO is defining the composition and structure of these multidisciplinary teams responsible for managing patients with NAFLD. We have a pretty good idea of who needs to be involved, but we need clear guidance in each context, in each setting, to make that happen, then to measure over time to see that it is happening, so we can start to report back that there's not just 7 published models of care that are fit for purpose, but 700, 7,000, 70,000. So moving from the expert recommendation on models of care, we carried out a global consensus that many of you were involved in on what needs to be done in order to have a proper, comprehensive public health response to NAFLD. NASH, 218 collaborators from 98 countries starting in December 2020, moving into mid-2021. 37 consensus statements were agreed on, 26 recommendations were made, covering topics from epidemiology and awareness, as well as models of care and treatment, to public health policies and leadership. They should have broad relevance. These are statements and recommendations that we can take to our policymakers, our decision makers, also at the hospital level. Now we need to leverage that and build on existing collaborations and efforts to have a multi-year global roadmap that's really multidisciplinary and including all global or key stakeholders that can address where we need to go in this field, by when, and how we're going to do that. This is what the recommendations look like. In the interest of time, I won't go through them all, but we did revisit models of care again a year later in this consensus statement. And again, it was focused on designing and implementing local care pathways, making multidisciplinary care models the norm, and equipping providers with the necessary tools and expanding the use of implementation research, because we realized with the expert recommendation that it was often very generic. We need to try this out in the different contexts, see what works, and share those lessons with others. Shira mentioned yesterday the recently published Lancet Commission called Protecting the Next Generation of Europeans Against Liver Disease Complications and Premature Mortality. I think many of the findings are relevant for the whole world, but the focus of that commission was on the European region, the large European region that covers 53 countries, the WHO region. We recognize the impact of the marketing of alcohol and ultra-processed high-sugar food and drinks to children in particular. One of the purposes of this commission was really to look at the next generation, to advocate for improved health promotion through access to healthy diets and physical activity. And we know it's not enough just to prescribe this. We need to also work with urban planners, city planners, and others to make sure that these green areas actually exist and that people can safely access them. That the endocrinologist should not miss NAFLD. I realize that the endocrinologists in the room are not the audience of this commission, but we know from so many studies and from our colleagues that in the diabetes field, NAFLD is really not being well addressed, and it's not uncommon to not even use non-invasive tests, which would be easy to carry out in that population. And finally, the commission recommended to develop a multi-stakeholder education program to reduce all forms of stigma. This was the figure that the Lancet Commission published. I won't go through it in detail, but as we talk about fatty liver disease, as was mentioned in the roundtable this morning, we need to remember the role of stigma. And when we talk about stigma, it's often used as a catch-all. We need to remember that there's public stigma, there's structural stigma, there's also stigma in health settings, and that leads to self-stigma. It's a very complicated very complicated concept, but there are clear consequences, and actually that's where we can also look at some of our endpoints. Are we losing people to follow-up, and why? Why is there care avoidance? Why is there delayed care? Is it on the part of the provider? Is it on the part of the patient? The increase in the number of people with severe liver disease, when we know there are actions we can do to prevent that. The increase in unhealthy behaviors, and so on. So how do we measure stigma? We can learn from the HIV field that published the HIV Stigma Index that's been carried out in a dozen countries around the world, will be used in Spain this year, reaching thousands of people living with HIV in a particular country with a whole set of questions that they can respond to. So the patient-reported outcomes that Zobair, Robert, and others have been mentioning that are so important. We can do this in stigma, and we can actually understand and get a composite number for how a country is doing in terms of stigma. Yesterday, I think it was you, Jose, who mentioned, or somebody, the importance of the Sustainable Development Goals. These are the UN goals that 193 countries have committed to achieving by 2030. As you can imagine, liver is not mentioned at all, but thanks to patient advocates led by the World Hepatitis Alliance, within SDG 3, hepatitis is mentioned, Viral hepatitis is mentioned to combat viral hepatitis, whereas the HIV advocates were a little stronger. They got to end HIV. When you look through the 100 targets, there's no target on hepatitis C. There is a target on hepatitis B. We need to make the Sustainable Development Agenda ours. So we published this sort of consensus study on which targets and goals are most relevant for us in fatty liver disease. We published it in December in APT. I was really impressed that it became the most downloaded article for a couple months in a row. People want to understand, what are these SDGs about and how do we use them? In the European Union, high-income countries, they've made it clear that they're committed to the SDGs. Often we see these development goals as something for lower-income countries, but the European Commission has expressly declared that their goal is to achieve the SDGs. We need to explain to them that NAFLD is a part of that agenda, that by engaging with us, we can start to knock off 1, 2, 17, and so on healthy spaces, on better education, on access to healthier foods, and so on. I'll start to wrap up, but I wanted to mention something that John Dillon alluded to yesterday about the hepatitis C care continuum. This care continuum was published by WHO in 2017, and it's what really guides the response in hepatitis C. On the left, you see the prevalence, all infected. Most countries weren't able to report prevalence. That pushes them to carry out those prevalence studies that we also need in fatty liver disease. Then how many people have been tested? We might ask, and which tests were used? How many people who were tested are aware of their status? We know many people with hepatitis C were lost to follow-up. They were deemed treatment ineligible. What's the situation for us? I think often we're flying very blind in the field of fatty liver disease. Even in hepatitis C, for most countries, we're not able to complete this continuum of care. You might say the story of hepatitis C ends when you've attained a sustained virologic response, an SVR, you've been cured. What WHO says in their wisdom is that actually we need to treat the patient, not just the virus. If you presented late, and in Spain, where I was told nobody presented late, we did a study and 26% of people who tested positive hepatitis C on their first hospital visit already had an F3 or an F4, which means that we can rather easily treat the virus, but then we need to maintain those patients in care. This is what the global cascade of care looked like for HCV when WHO agreed on their first strategy in 2016. This is 2015 data. So the estimate was 71 million people living with hepatitis C. Look how few were diagnosed. Look how few are treated. Could we do this kind of simple cascade of care for fatty liver disease? I don't think so. That's another endpoint to be able to fill that in. So what we did for HCV was develop a simple cascade of care with just those 3 main endpoints: infected, diagnosed, treated. Now we know that if you take your HCV treatment, you'll most likely be cured, so even that's not as important to report. We need to think through what that will look like for fatty liver disease. Maybe it's a theme we can take up next year. So let me close by saying that, when we've looked back over just the last couple of years, I think, Donna, you mentioned that it's, 5, 7 years ago, fatty liver disease was just not on the agenda in terms of public health, or really in terms of health in general outside of the liver specialists. When we looked at the situation around the world, we found that most countries are unprepared. We developed a consensus statement to move the field forward in terms of public health. We put out the expert recommendation on models of care. Now we need to think how to measure that. EASL took it up with the Lancet and came with a much broader set of recommendations, and now it's building on the multidisciplinary coalition that GLI and others are leading, and to develop jointly that kind of roadmap that will drive the agenda forward around the world, engaging with WHO, engaging with other key stakeholders. So we'll need to report these successful models of care to address NAFLD-NASH, what worked, how were they achieved, advance that agenda, and engage with communities outside of liver health, which has been one of the purposes of this meeting, but it's also something we need to do in other meetings to make sure we're able to engage with our colleagues in other fields so that fatty liver disease gets on the agenda there as well. thank you, and let me acknowledge Marcelo, who's here from my team, and others who have been contributing to this presentation. Thanks.